To load the harpoon syringe, retract the harpoon and insert the cartridge. The rubber stopper must be attached to the harpoon to allow for aspiration before anesthetic solution is deposited. Once the harpoon is securely engaged, attach a needle of correct gauge and length to the syringe. When the syringe is assembled, remove the needle cap and express a small volume of solution to ensure the needle has penetrated the cartridge diaphragm and that the plunger is not sticking to the inside of the cartridge.
Locate and palpate landmarks. Because of individual anatomic variation, it is critical for clinicians to palpate the appropriate landmarks prior to inserting the needle for any injection. Adjustments in technique are made according to size and shape of skull, location of foramen, and height of vestibule. Dry injection site with a sterile gauze square and apply topical for no less than 1 minute. By drying the injection site, the effectiveness of topical anesthetic is increased, and the improved visibility makes it easier to orient the bevel of the needle. Remember that topical anesthetics also have maximum safe dosages. Therefore, apply only a small amount for the appropriate length of time. Do not rub the tissues with the applicator, but rather place the applicator on the insertion site. Keep the area dry. This preparation time can also be used to rehearse the injection by mentally reviewing the particular injection technique for the area being anesthetized. Obtain good retraction and keep the tissue taut. The use of a sterile 2x2 gauze helps to keep the lip from slipping away during retraction and to hold the tissue tense or taut, thereby allowing the needle to slide through the tissue easily, which contributes to an atraumatic injection. Orient the syringe by assuring that the bevel of the needle will face the bone and the large window of the syringe will face the operator. The large window of the syringe should always be turned toward the operator during an injection to allow the operator to easily observe the speed at which the solution is being deposited and whether the aspiration is positive or negative. Many clinicians believe the bevel of the needle should be facing the bone prior to needle penetration so that the anesthetic solution automatically flows toward the nerve and to increase patient comfort. Always attempt to keep the syringe out of the view of the patient. It's much easier to keep the syringe out of the view by placing the tray setup behind the patient's head. For clinicians with across-the-chest delivery systems, it might be necessary to use a mobile cart to achieve this arrangement. Attempt to cover the patient's eyes with your non-dominant hand when bringing the syringe close to the patient's mouth. Under no circumstances should the syringe be brought directly across the patient's eyes. Attempt to fulcrum. The clinician should always attempt to obtain a stable fulcrum. There are several fulcrum positions that can be employed to assure stability during the injection. Keeping the elbow down and as close as possible to the body offers more stabilization than an arm that is elevated and in a still frame position for the entire minute it takes to deposit a cartridge. Keep the palm and wrist facing up. For better control of the syringe during aspiration and deposition, the pad of the thumb should be placed on the thumb ring and the ring should not slide below the knuckle. With the syringe securely placed in the hand, the palm and wrist should be facing upwards toward the ceiling. Again, this allows the operator better control and comfort throughout the injection. Another method to increase stability, particularly in the anterior region where clinicians tend to have less stability because there are no surrounding tissues to help support the syringe, is shown here. The thumb of the non-dominant, the retraction hand, is placed against the barrel of the syringe or a finger of the dominant hand to create a bridge of stability. A finger of the dominant hand can also be placed on the patient's chin along with the palm-up grasp position to provide stability. Penetrate the mucosal tissue with the needle 1 to 2 millimeters, or just until the bevel of the needle is embedded in tissue. Some clinicians feel it is more comfortable for the patient if you drop a few drops of solution and wait a few seconds to anesthetize the area of insertion prior to proceeding. Next, advance the needle slowly. This step is critical for administering atraumatic injections. The clinician that advances the needle very quickly is guaranteed to cause discomfort for the patient. Depositing a drop or two of solution in advance of the needle to anesthetize the area on the way to the deposition site is an acceptable procedure for increasing patient comfort, but the operator must be careful to use only a slight amount of anesthetic because the bulk of the solution must be reserved for the nerves to be anesthetized. Aspirate at the deposition site before depositing solution by pulling back gently on the thumb ring. If the aspiration is positive, blood will enter the cartridge. Even a slight hand movement will relocate the needle tip, resulting in the need to re-aspirate. Relocation of the tip of the needle increases the chance of depositing in a vessel and creating a toxic reaction. If the aspiration is negative, begin to slowly deposit solution. In deeper injections and highly vascular areas, such as the posterior superior alveolar or the inferior alveolar, more than one aspiration should be performed. Aspirating on 2 different planes is recommended by many clinicians to assure that the lumen is not blocked, preventing ineffective aspiration. If the depth of the needle changes at all during the injection, be sure to re-aspirate. If aspiration is positive, assess the amount of blood that has entered the cartridge. If there is just a small trickle, re-aspirate, and if negative the second time, continue with depositing. If cartridge is clouded with blood and therefore you are unable to ascertain whether or not the second aspiration is negative, the clinician must change the cartridge and either replace the needle or expel a bit of solution to clear any hemorrhage in the lumen. Then re-inject. Explain the situation to the patient in a calm, composed manner. Slow deposition of the solution is another critical step for administering atraumatic injections. To increase patient comfort and decrease the chance of toxicity, the anesthetic should be deposited no faster than 1 minute per cartridge. Procedures with longer durations will require more anesthetic. Some patients will require greater volumes even for relatively short procedures. Volumes recommended in the individual technique videos are minimal amounts to achieve pulpal anesthesia. Remember that the anesthetic cannot be deposited any faster than 1 minute per carpule. Here is an example of an appropriate deposition rate. In this demonstration, the anesthetic is being deposited much too quickly, which will compromise patient comfort and increase the risk of toxicity. The clinician must remember to communicate with the patient throughout the entire procedure. Besides maintaining supportive verbal communication, it is important to observe the patient's face and body for signs of discomfort during the procedure. Speak to the patient in a positive, reassuring manner, remembering that the patient cannot answer questions. Do not leave the patient unattended after administering local anesthesia. If an adverse reaction occurs, it will usually happen within several minutes after the injection is administered. Finally, withdraw the needle slowly from the tissue and make the needle safe using an accepted recapping technique. A variety of commercial needle guards are available for healthcare professionals. Needles must not be recapped without using one of the many protective barrier devices. It is permissible to use a one-handed scoop technique to replace the needle sheath. Rinse the mouth. Sometimes a drop or two of anesthetic will inadvertently drop into the patient's mouth, leaving a very bitter taste. For patient comfort, be sure to rinse the mouth immediately after making the needle safe. Then assess the patient's comfort with the procedure. The needle is then carefully discarded in a clearly identified, puncture-resistant and leak-proof sharps container according to the standard operating procedures of your facility. Make an appropriate chart entry to document injection specifics and indicate whether
needle bevel orientation can have an impact on both patient comfort and needle deflection during insertion. A number of needles are available that have a marking on the needle hub corresponding to the location of the needle bevel.
Maxillary infiltration is used to achieve pulpal anesthesia of one or two maxillary teeth. The area anesthetized is the pulp and the buccal soft tissue and bone of the tooth anesthetized. The recommended needle is a 27 gauge short. The insertion site is in the height of the mucobuccal fold over the apex of the anesthetized tooth. The needle is held parallel to the maxillary bone and inserted until the needle tip is at or above the apex of the tooth. After 2 negative aspirations, 1/3 of a cartridge of local anesthetic is slowly injected.
An infiltration injection anesthetizes the pulpal and osseous tissues, periodontal ligaments, facial gingiva, and vestibular mucosa of a single tooth. Because of the density of the bone on the mandible in adults, infiltration injections are rarely administered for mandibular anesthesia, but are used routinely and effectively for maxillary anesthesia. The ASA and the MSA injections follow the exact same technique as described for this injection, the only differences being the size of the area anesthetized, which is due to anatomical nerve placement, and site of needle penetration. A local infiltration anesthetizes a smaller area than the ASA or MSA, which are commonly referred to as field blocks. The landmark for this injection is the height of the mucobuccal fold in the area of the tooth to be anesthetized. For this demonstration, tooth number 7 will be anesthetized. This tooth has been selected because of easy accessibility and visibility. Palpate the root eminence and apex. The apex is the ultimate destination for depositing solution. Place topical at the mucobuccal fold above the tooth. While the topical is in place, use both hands to obtain and ready your syringe, making certain that the bevel is toward the bone and the large window toward the operator. Follow all the procedures presented in the video clip entitled Basic Steps in the Administration of Local Anesthesia. For this injection, a 25, 27, or 30 gauge short needle works well. The penetration site is at the height of the mucobuccal fold over the individual tooth. To gain access to the site of penetration, gently retract the tissue, pulling the tissues taut while lifting the tissue away from the maxilla. The pathway of the needle is parallel with the long axis of the tooth. Insert the needle approximately 3 to 6 millimeters. The apex of the root will determine the depth of the insertion. Aspirate at the deposition site. Then deposit approximately 1/3 of a cartridge, depending upon patient factors and the procedure being performed, over a period of not less than 30 seconds. Finally, withdraw the needle slowly from the tissue and make the needle safe using an accepted recapping technique. Potential complications from this injection are minimal. There is the possibility of discomfort if periosteum is contacted. Be sure to stay parallel with the long axis of the tooth to avoid contact with the periosteum. You may also see some postoperative edema and/or hemorrhage in the area from needle puncture.
Supraperiosteal or maxillary infiltrations are very useful injections to anesthetize individual maxillary teeth, be it an incisor, canine, premolar, or molar. Each maxillary tooth receives pulpal innervation from small branches of the second division, which is the maxillary division, of the trigeminal nerve. The maxilla's alveolar bone is porous enough to allow anesthetic solution to diffuse through the bone to the terminal branches of the anterior, middle, and posterior superior alveolar nerves. This simple method achieves profound pulpal anesthesia in a very localized area. The buccal bone and labial soft tissue are also anesthetized by these injections. The target area for deposition is the bone overlying the apex of the desired tooth root. The client is in a fully supine position. The right-handed operator sits at 9 o'clock. Firmly retract the soft tissues. Establish the landmark by estimating the length of the tooth root and the position of the root apex. If available, a periapical radiograph may be used to confirm the length of the tooth root. Apply a small amount of topical anesthetic for 1 minute. Prepare your syringe with a 25 or a 27 gauge short needle, orienting the bevel of the needle towards the periosteum. Direct the syringe parallel to the long axis of the tooth. Insert the needle a few millimeters beneath the mucosa until the tip of the needle is at the apex of the tooth root. Injection depth varies depending on vestibule height and the length of the tooth root. However, in most cases, the needle need only be advanced a few millimeters. If bony contact is made, withdraw the needle 1 millimeter to minimize client discomfort during injection. Aspirate, and if negative, slowly deposit 0.6 to 1.8 milliliters of anesthetic solution. Volume is determined by the individual tooth. For example, multi-rooted teeth will require more anesthetic. Volume is also affected by whether or not the client requires pulpal or soft tissue anesthesia. More anesthetic will be needed to fully penetrate a nerve and anesthetize all of its nerve fibers. An in-depth discussion of this principle can be found in many textbooks on local anesthesia. Once the solution is deposited, slowly withdraw the needle and safely recap.